Good afternoon, Africa. I am Dr. Rahul Mandlik from Shalina Healthcare. Welcome you all to our webinar series. Today, we are going to discuss one of the burning topic, the health issue that has put Africa under pressure and which is the cause for 50% of cardiovascular diseases, stroke and heart failure, and which is nothing but the hypertension, that is increased blood pressure. So today's panel discussion, that is Heart Talk 2 in this webinar series, is being organized to mark May Measurement Month, which is just to create more awareness about this silent killer. And the title of today's panel discussion is Hypertension Management at the Community Level in Sub-Saharan Africa towards a rational use of available resources. This program is brought to you by Shalina Healthcare. We are operating in Africa from last 40 years, and since then it has been our mission to manufacture quality and affordable medicine and to make it available across the region. Today we are one of the largest pharmaceutical companies across the region, and we have achieved this by manufacturing our products at our own WHO approved facilities. Since we are the leader, we own this responsibility towards the society as well as towards our healthcare professional network. And this webinar series is part of that. So we have initiated this unique program, that is Shalina Academy. And under this banner, we are conducting series of online as well as offline educational programs, which are being attended by hundreds healthcare professionals every month. So today, I feel that we are fortunate enough to get very renowned and senior panel members who are the national level presidents of heart related bodies. And with this, let me welcome our honorable panel members. Professor Omotoso, sir is currently associated with Department of Medicine at College of Health Sciences, University of Ilorin, Nigeria. He is a consultant physician, cardiologist at Division of Cardiovascular Medicine, University of Ilorin Teaching Hospital. And Dr. Omotoso is current national president of Nigerian Hypertension Society. He is the chief examiner of Faculty of Internal Medicine, West African College of Physicians. And Dr. Omotoso is past Secretary General of Nigerian Cardiac Society. He is a member of Medical and Dental Council of Nigeria Accreditation Panels. Dr. Omotoso has been facilitator to various NMA and ARD workshops since 1984 and also regular resource at annual West African College of Physicians update courses. Dr. Omotoso he is a scientific reviewer for number of journals, and Professor Omotoso has published more than 70 articles in peer-reviewed journals. Welcome to you, sir.
Thank you.
I would like to welcome now Dr. Doku. Dr. Doku is head of cardiology at UGMS Korlebu Teaching Hospital in Accra, Ghana. And sir is current national president of Ghanaian Society of Cardiology and country director of Ghana Heart Initiative. Dr. Doku has got training in cardiology in Ghana as well as Germany, and he is a lecturer with University of Ghana Medical School since 2016. Dr. Doku is a fellow of German Cardiac Society, West African College of Physicians, and Ghana College of Physicians and Surgeons. Dr. Doku is the director of African Air Ambulance Foundation, and sir has published 16 publications in peer-reviewed journals. Welcome to you, Dr. Doku. And now I would like to welcome Dr. Gade. Dr. Gade is head of cardiothoracic service at Clínica Sagrada Esperança in Luanda, Angola, where sir is working as a founder of cardiothoracic services, and he is a main cardiothoracic surgeon and emergency permanent assistant. Dr. Gade is also associated as a coordinator of cardiothoracic services at Clínica Girasol in Luanda, where he is a main cardiothoracic surgeon and emergency permanent assistant. Dr. Gade is current national president of Angola Cardiac Society. To mention some of his core expertise, like cardiac and thoracic patient approach, cardiac and pulmonary analysis interpretation, hypertensive emergencies management, arrhythmias management, emergency pacemaker implantation, cardiac and thoracic surgery performing, acute heart failure and cardiac low output management, acute coronary syndrome management, and so on. And I would like to welcome Dr. Gade.
Okay, thank you very much.
So, before we start with the actual panel discussion, I would like to inform our audience that you can get the certificate of participation signed by our respected panel members immediately after this program. So, at the end of the program, you can attend the quiz. You can see the quiz option on the screen on the right hand side, where you can click on that and you can take the small quiz, and you will be able to get your certificate of participation. At the same time, you can also post your queries, your questions, and even suggestions in the box provided on the right side. That will be discussed towards the end of the program during Q&A session. Thank you so much. I would like to hand over the session now to Dr. Omotoso, please.
Thank you very much, Dr. Rahul. This evening's interaction or webinar is in two parts. The first part, as coordinator, will be to give an overview of today's discussion, very brief overview, before the two main speakers will come online. And in doing that, it's going to be a reminder of some of the things that you already know as primary care physicians, as nurses, as pharmacists, and a good reminder at that, so that it will positively impact on our care of patients with this all-important subject. As I've been introduced, I'm A.B. Omotosho, a professor of medicine and the current president of the Nigerian Hypertension Society. Now, next slide, please. Hypertension is a progressive cardiovascular syndrome arising from an interplay of complex etiologies. And early markers may even be present before the blood pressure is elevated beyond thresholds. And the progression is slowly associated with functional and structural cardiac and vascular abnormalities that can damage the vasculature, damage the brain, damage the heart, and other organs, and lead to premature death. And you can also define it as the blood pressure at which the benefit of treatment outweighs the risk of treatment. Using this definition, aims at improving identification of individuals who are at risk at an earlier point in the progression of hypertension. And the global assessment will include early markers of cardiovascular disease and target organ damage. Markers like the age, the gender, comorbidities, lipid levels, body mass index, family history, and so on and so forth. And there are other signs that physiologically will show exaggerated blood pressure response to certain events like exercise and also mental stress, evoking an exaggerated blood pressure response. Or somebody with microalbuminuria or impaired glucose tolerance. All these are early things that one should look out for. So globally, an estimated 26% of the world's population, and that is about 972 million people, have hypertension, and the prevalence is expected to rise to 29%, from 26% to 29% of the global population by the year 2025. And in absolute number of people rose from 600 million in 1980 to 1 billion in 2008, and is projected globally to be 1.56 billion by 2025. In Africa, the estimated number of people with hypertension has increased steadily over the years from 1990, from 54.6 million estimated in 1990 to 92.3 million in year 2000. That's a period of 10 years. That's a 70% increase. And 130.2 million year 2010. That is 41% increase from the year 2000. So it's a progressive increase in the number of affected people globally. But the focus of today's discussion is Africa, sub-Saharan Africa. So it is projected that this figure will rise to 216.8 million by the year 2020, another 66% rise from year 2010. And here, a number of studies that have been conducted in various parts of Africa reporting the prevalence rates from West Africa, both urban and suburban or rural areas, in Southern Africa, in East Africa, with various prevalence rates going as high as 46.4% in the West, 34.3% in the South, and up to nearly 30% in the East. This is just to underscore the fact that hypertension is very prevalent in our setting, in the African setting. And as such, concerted efforts should be made at addressing this subject matter. And also bearing in mind that hypertension, apart from being very prevalent, is the #1 risk factor for global mortality all over the world. When you look at the other risk, cardiovascular risk factors or causes of death, tobacco use, lipid derangement, underweight, high body mass index, physical inactivity, use of alcohol. Hypertension is the #1 risk factor for global mortality. And therefore, we should note that globally, we do know that cardiovascular disease accounts for approximately 17 million deaths a year, which is nearly 1/3 of the total global deaths. And of this global mortality, complications of hypertension account for 9.4 million deaths globally every year. And hypertension is responsible for at least 45% of deaths due to heart disease and 51% of deaths due to stroke. And we know that nearly 80% of these deaths occur in low and middle income countries, including sub-Saharan Africa. And this is to emphasize the fact that hypertension is a global threat. Hypertension is a major cause of global mortality and is particularly so in low to middle income countries where most countries in sub-Saharan Africa are found. Now, just quickly, etiological, when you talk of hypertension, talk of classification, and there are different ways of classifying hypertension. But this slide is just to talk to us about the classification of hypertension based on etiology or risk factors. Broadly, hypertension can etiologically be classified into two. The essential hypertension, some call it primary hypertension, and it is largely of unknown etiology, constituting about 90% of cases. However, certain risk factors have been identified as being very important in this form of, in this class of hypertension. And some of these risk factors, some will still be mentioned down the line by other members of the panel. But as a quick reminder, obesity, high salt consumption, excessive alcohol intake. These are some of the risk factors. Stress, heredity, physical inactivity. These are risk factors that have been associated with essential hypertension. Knowledge about this becomes very crucial when we talk about the prevention of development of prevention and also management or treatment of essential hypertension. We do know that some of these risk factors are fixed, some are modifiable. Indeed, the only one here of these few items that I've put there that you may say it appears fixed is heredity. All the other ones can be modified one way or the other, and the modification of these risk factors will also help in modifying or modulating the blood pressure elevation. And then the second broad class, which constitutes about the remaining 10% of cases, are the secondary hypertension. In this class of hypertension, specific causes can be identified. And grossly or broadly, these causes include renal causes, renal diseases in various forms, endocrine pathologies like hypothyroidism, even comorbid conditions like diabetes, Cushing's disease. All these are secondary causes of hypertension. Now, we've been talking about hypertension being a major cause of global mortality and morbidity. Let's quickly remind ourselves that hypertension is often asymptomatic, except when there is organ damage. And the implication of that statement is the fact that hypertension is regarded as a silent killer, in the sense that the first major presentation may be when there is an acute complication. And some of these complications include stroke, that is cerebrovascular accidents, TIAs, heart failure. Indeed, in this part of the world, hypertension is the most common cause of chronic heart failure. In some other parts of the world, it may be coronary artery disease or some other causes, but in sub-Saharan Africa, when we talk of heart failure, hypertension plays a major role as being the most common cause of heart failure. Hypertension is also one of the underlying risk factors or causes of coronary artery disease. Just as I said that hypertension can be due to chronic kidney disease or resulting from kidney pathology, chronic hypertension can also be a cause of chronic kidney disease. Indeed, again, in this part of the world, hypertension is one of the most common causes of chronic kidney disease. Similarly, peripheral arterial disease can result from as a complication of hypertension. With all these complications, it becomes obvious that in terms of contribution to mortality, hypertension plays a major role, and addressing hypertension will mitigate or lower these complications. And in the terms of principles of management of hypertension, the institution of total cardiovascular care is important. And broadly speaking, the principles of hypertension management include the confirmation of chronic elevation of blood pressure and to determine the actual level, and to also exclude or identify secondary causes of hypertension, as we said earlier on. The 10% of secondary hypertension, if one removes the underlying cause, one can start talking about possible cure at that level. So we need to exclude that the case that we're seeing is either primary or secondary, and if it's secondary, to identify the secondary causes in such a situation. And also, as part of the principles of management, is to holistically, a package of total cardiovascular care is to determine the risk for the development of cardiovascular disease in individual patients, and to determine the presence of target organ damage and quantify its extent. And this will also be in relation to risk stratification that I've mentioned. And also to search for other cardiovascular risk factors. Some of them have been mentioned, some will be mentioned as we go on in this program. And clinical conditions that may influence the prognosis and treatment. In other words, you look for comorbid conditions. And that is part of the principle, to identify and treat other comorbid conditions. And if we're able to manage hypertension effectively, or effective management of lowering the blood pressure, we expect that there will be significant reduction in the complications. For instance, reduction or lowering of the blood pressure can reduce stroke incidence by about 35 to 40%, myocardial infarction by about 20 to 25%, and heart failure complication by about 50%. Now, in view of all these things, in view of the high prevalence of hypertension globally, but particularly in low to middle income countries, sub-Saharan Africa, and the resulting or consequent complications and mortality associated with this condition, global, total burden of hypertension in this region, and also globally, May 17th of every year is dedicated to World Hypertension Day. And this as a result of the rapidly growing burden of hypertension globally. One of the earlier slides showed the progressive increase over the past 30 years in the prevalence of hypertension and contribution of hypertension to global burden of disease over the years, the International Society of Hypertension, in league with World Hypertension League, have designated the entire month of May as May Measurement Month. And this has been on for the past, I think roughly the past 5-6 years, such that the whole of the month of May, measurements, community measurements of blood pressure aimed at screening millions of people above 18 years of age worldwide. And this exercise also is to create awareness about hypertension and its possible complications and impact, not only on individuals, but also on the larger population, regional and globally. And the MMM is also to generate prevalence and other useful data. I must say that aggregates of the various findings in the past few years of May Measurement Month have been published for the various countries. For Nigeria, for other countries, we have generated data and publications pointing at the prevalence and also some peculiarities of hypertension in the various countries. And it's also aimed at not only generating this data, but also at to motivate governments to institute policies aimed at reducing the burden of hypertension. So, distinguished audience, the essence of today's webinar is in recognition of the May Measurement Month, the impact, the importance of that exercise, and the contribution that the exercise gives or generates, or the contribution into the body of knowledge, the body of information, and also in creating awareness. You'll see figures later on to show that the percentage of, the prevalence and the percentage of people that have been found in the various screening exercises to be aware that they are hypertensive, and even those that are aware, the percentage that have been on treatment, and those that have been on treatment, what percentage of them have been controlled. All these are figures, all these are pieces of information that are very vital in public health care, particularly in relation to hypertension and its sequelae. So, to give more details into this discussion, having given this overview, Dr. Doku will be looking at another aspect of this discussion, and that will be the burden and the gaps in the management of hypertension in Africa. Having identified the fact that this is a major global problem, and with treatment you can mitigate, we can reduce the complications. Do we have this treatment being available to everybody? What are the gaps, the burden and the gaps in the management of hypertension in Africa? Dr. Doku will go through that, and thereafter we'll call on Dr. Gade after Dr. Doku. So, Dr. Doku, you're welcome to the platform.
Prof, for giving an overview, and thank you, Shalina Healthcare, for inviting us to be part of your program today. Indeed, as Prof said, hypertension is the main driver of morbidity and mortality across Africa. This problem is increasing. If you look at Sub-Saharan Africa, 50 years ago, you hardly see an African with hypertension. But over the years, hypertension became a common problem within Africa. So that will be my task. And as Prof said, we are commemorating the World Hypertension Awareness Month. That is the May measurement month, trying to build capacity, find the problem, and identify these patients with hypertension and link them to care. So, unfortunately for us, Africa is a continent that has a very high burden of diseases. If you look at the global burden of diseases, even though Africa contributes about 15% to the global population and less than 3% to the global economy, even some estimated to be 0.5% of the global economy, Africa carries about 25% of the disease burden. Most of these disease burden are non-communicable diseases, which is over 60%, even 80% in some places, and not contributing to significant number of deaths. So Africa, a continent that majority of the people, are low in income, low GDP, but high burden of diseases, and that is what it is. And how can we address this? If you look at the burden of diseases and its contribution to the life of a country, you would realize that non-communicable disease, that is diseases from cardiovascular problems, from diabetes, from respiratory, from cancer, that burden to a particular country far outweighs the burden from communicable diseases like TB, HIV, malaria. So if you look at this slide, you look to my left, it tells you a lot of problems, a lot of information. One, the countries to the far left are these countries with a low GDP per capita or gross national income per capita. So these are the countries to my left, and most of these countries very poor. But if you look at it again, you realize that these countries have two problems in terms of diseases. They have both communicable diseases and non-communicable diseases. So if you look at those countries, some have even higher levels of non-communicable communicable diseases like malaria, HIV, and others also have non-communicable disease. So this is what we call the double burden of diseases. So the African countries have low income levels, have high burden of diseases, and the impact of the disease in the economy is so huge. The other thing we can also deduce from this slide is that if you compare non-communicable diseases to communicable diseases, non-communicable disease impact on the economy is far, far more. That's the disability adjusted life years lost are a lot more. And as we mentioned, hypertension and cardiovascular disease and most of the NCDs are very young people in Africa, productive age group. So this is the four or so information that we need to get from this slide. That yes, Africa, as you're aware, is a low-income country. Some are middle-income country, majority are low-income country. We have a higher burden of diseases, most of which are communicable, some non-communicable, and we have a double burden of these diseases in our country, and that communicable diseases have a higher impact, non-communicable have a higher impact on the lives of the African than the other ones. So let's look at where we are. Prof mentioned that the cardiovascular disease, driven mainly by hypertension, has been increasing in the past years because of changing lifestyle in Africa, because of poor diet, lack of exercise, rural-urban migration. So if you look at the last few years, hypertension and its complications have more than doubled in most countries in Africa. If you look at across from the east to the west of Africa, you see that the burden from cardiovascular disease, the number of people who die from stroke have more than doubled. The number of people who die from kidney disease from hypertension have more than doubled. The number of people with complications from diabetes have also doubled. So it's a problem, and that the poor continent is now saddled with increasing burden of cardiovascular diseases. Now, if we look at the contribution of hypertension to most of these problems, as Prof mentioned, contributes to heart failure, contributes to kidney disease, contributes to stroke, and several other complications. So on average, the main driver of stroke in Africa is hypertension. The main driver of heart failure in Africa is hypertension. And the main driver of kidney disease in Africa is hypertension. So hypertension and its impact on society is huge. Of course, other risk factors also contribute: high cholesterol, dyslipidemia, obesity, smoking, excessive alcohol intake, physical inactivity. They all contribute. But the good news is that if we are to, reverse the situation in Africa, our best bet is to look at a more, cost-effective way of approaching this. That's the population-based interventions such as lifestyle changes by people increasing, their exercise level, people taking low carbohydrate diets, low fat diet. So hypertension is a major contributor of the deaths in Africa through strokes and through other complications. And if you look at Ghana and most African countries, for the last 5 years, hypertension-related morbidity, mortality are leading the charts. In Ghana, for the last 5 years, hypertension-related stroke, hypertension-related heart disease have been leading the mortality charts for some time now. So it's a major problem that we need to address. Most Africans have moved from the villages to the cities. We are eating more carbohydrate-based foods. Yet, because we move from the village to the cities, our activity levels are low. Prevalence of obesity across Africa is increasing at an alarming rate and is a major contributor of most of the morbidity and mortality problem that we have in Africa. And we need to address this. So because of this changing lifestyle, because of these changing problems, and also because of the genetic and environmental factors, we have increasing burden of hypertension, which is driving all this. And across Africa, prevalence of hypertension in most adults in Africa is about 30%. So it's a big problem in Sub-Saharan Africa, and that is what is driving most of the morbidity and mortality across Africa. One big question is this: even though most countries in the Western world have prevalence of hypertension in adults more than 30%, the mortality from hypertension are far less than what we have in Africa. The question is, what is the reason? What is causing this? It is mainly because Africans have not found a way of managing hypertension, having the health system strengthening approach, population-based approach, and screening services to identify hypertension and link them to care. So if you look at hypertension and the havoc it's causing across Africa, you can liken it to a heavy storm, a tsunami that is hitting Africa. Some parts of Africa are really being affected by this storm, and majority of countries will be affected. Majority of countries are suffering from it. So you look at this picture, you see that the storm that is hitting Africa, but it appears the health system in most African countries are not prepared to manage it. Most people in Africa are not aware of the burden of hypertension. Most of them don't feel anything, and so, as Prof mentioned, it's largely symptomless. And most people don't have their blood pressure checked, so they are not able to identify it. And most of them, by the time they know they have hypertension, they have a complication, some of which end, in deaths. Some, results in, irreversible damages and complications. So, hypertension's havoc is raging across Africa, yet the system in Africa is not responsive to this problem. Why am I saying so? One of the problems is that allocation of funds to the management of hypertension in Africa, as well as non-communicable disease across Africa, is disproportionately low. If you compare the allocation of funds to malaria, HIV, TB, constitutes over 30%. But if you look at the allocation of funds to non-communicable disease, including hypertension and other cardiovascular problems, only about 2%, or even less than 5% across Africa are allocated to management of cardiovascular disease, NCDs. So the health system is really not, responsive. It's not really identifying cardiovascular disease and NCDs as a major problem. And if you look at most countries in Africa, majority of the funds come from abroad, from foundation, from WHO, World Bank, Global Fund. Yet most of these funds go to malaria, TB, HIV. Very little is going into non-communicable disease, including hypertension, including diabetes, including heart failure, stroke, and the rest. So that is where one of the problem is. The health system is not responsive enough. And so what we have is that hypertension as a major problem in the society is largely undetected. Over 50% of the patients with hypertension in the community have not been screened for it. So they just walk around and they are not aware. In fact, some instances, about 70% of hypertension inside are not aware. And those who are aware, this is about half of them, are diagnosed, are diagnosed, and then the percentage treated, just about 22% of the total population. And those who are on treatment, significant number of people are not controlled. So if you look at 100% of the hypertension in the community, less than 10% of them have their blood pressure controlled. So, ladies and gentlemen, this is what is driving a complication. This is why in most countries in Africa, hypertension is driving morbidity and mortality, causing the strokes, the kidney disease, and then the heart diseases, and playing the leading role in causing morbidity and mortality. So, how can we manage this? The best way is to build a national capacity to manage hypertension and other cardiovascular diseases. If you look across Africa, there's a lot of ignorance. People really don't see the need. Yes, population-based education and intervention can help, but the health system itself needs to do more. We need to allocate more resources to the care of hypertension. And these are some of the steps we can take in managing hypertension across Africa. One, we need to build capacity enough to strengthen the health system. We need to develop guidelines. We need to allocate more funds. We need to incorporate hypertension care in NCD programs across the country, and we should give it a priority. We should develop policies and several other interventions to make sure that, yes, we have hypertension under control. Otherwise, it becomes a talk shop, because a lot of our patients who have hypertension, a lot of people with hypertension are not aware, and they're in the community. These are the people who will come to the secondary and tertiary level for care. And some of them with complications that we can't do anything about. But I liken the problem of hypertension in the community to having a tap that is overflowing in your kitchen. You can decide that you're going to take a mop to mop the floor. I think the best way is to close the tap. If you close the tap, that is, we go after those who have the hypertension within the community, detect them and link them to care. That is the only way we can prevent the mortality and morbidity from hypertension in the teaching hospital and middle level facilities. So it's a problem we need to work on. So in conclusion, of course, we have increasing cardiovascular disease burden, and this is driven mainly by hypertension. So we have increasing burden of hypertension, over 30% across Africa in adults, increasing burden of diabetes, increasing burden of obesity because of poor diet and low exercise level. This is driving the strokes, this is driving the heart disease, this is driving the kidney disease. Yet, the health system in Africa is not well developed to manage this. So we need to do more allocating funds, using policy, developing guidelines, improving the health system to manage the vascular disease, especially managing hypertension. Thank you very much.
Economy, and yet we have 25% of global burden of disease coming from Africa. And you have also talked about, the increasing burden of cardiovascular risk factors, from hypertension to diabetes to obesity to dyslipidemia, and capped it by emphasizing the disproportionate allocation of resources, or the weak health systems in Africa not being able to adequately cope or address the burden of disease from hypertension. I'm sure there'll be a few questions down the line later on. We'll quickly move on to Dr. Gadi, who will be talking to us about hypertension management, particularly within the context of current guidelines. Dr. Gadi.
Okay, thank you very much, Professor Motozo. And thank you, Shalina, for inviting me to share acknowledgement with all the audience about this topic. Moving on forward, we're going to talk about hypertension management according to the current guidelines. And for this purpose, we are going to rely on some guidelines. I cannot move the slides. I cannot change the slide. Okay. For this purpose, we are going to rely on some guidelines. Essentially, the guideline from International Society of Hypertension has it englobe in its discussion all aspects that are present also in other guidelines, just like European one and American Cardiology College. And some aspect we are going to use as background the PASCAR roadmap of hypertension. Well, we are talking about high blood pressure, and for its correct management, the first step is to get the correct measurement of hypertension. So there is some guideline from PASCAR of how to take the reliable pressure values, address it to the patient, and address it to the blood pressure measurement itself. So once we have a diagnosis, the next step is to follow through this diagram, while we have to treat each one according to special situations. Well, I beg to hang on with me in this first step. It's a lifestyle changing. It's important step because I think that everybody going to follow me. It's a very important step because it's cheaper. It's relevant because it's costly. It's not costly for everyone. It's available for everyone, and it has a great contribution to lower the blood pressure. We are talking about lowering blood pressure through cheaper things, through things that everyone can do, things that are available to everyone independently on the setting, and limited resource in present or in the presence of resource. We are talking about moderation. We are talking about insult reduction. There is a strong evidence for relationship between high salt intake and increasing blood pressure, reducing salt added when preparing food at the table, avoiding or limiting the consumption of high salt foods such as soy sausage, fast food, and processed food, including breads and cereal with high salt. Moderate alcohol consumption. It's linked with it's a positive. It has a positive linear association between alcohol consumption and blood pressure, and the prevalence of hypertension and cardiovascular disease risk. Smoking cessation is very important. It's a major risk of several cardiovascular diseases and chronic obstructive pulmonary disease and cancer as well. Smoking cessation and the referral to smoking cessation program, it's strongly advised. Regular physical activity is also advised. Reducing stress and inducing mindful activity, complementary alternative of old traditional medicine. As we know, in our reality, there is a large proportion of hypertensive patients that use complementary alternative or traditional medicine to treat the hypertension in a larger scale. So it's advised that we should be careful about that because there is no strong evidence that this practice indeed contribute to lower high hypertension values. So it's advised that most strong and evidence must be produced so that this practice might be associated in method to lower the blood pressure and to reduce exposure to air pollution and cold temperature in some realities. And there is a wide range of antihypertensive medicines. And here we have the main class of antihypertensive drugs that I use it in every place. We can use it we can use them in a wide range, or according to the specific situation that are stated in this core drug treatment strategy. We have two settings. We have a setting with low resource, or with limited resource, and we have another setting where we have a possibility to treat optimally the patient. In the first setting, where we have limited resource, any strategy is advisable. So we can use whenever drug that is available. We can use free combinations, or one if there is not availability of combination pill. It's advisable using thiazide diuretic and thiazide-like diuretic, and not if thiazide-like diuretic are not available. And it's advised also using alternative for calcium blockers if there is not available, or tolerate non-dihydropyridine calcium blockers, as dithiazide and verapamil. When we have a resource, we have several steps where we can use ideally single pill combination therapy. And here we have the strategy. In the first step, where we have elderly people or people with low risk association of using inhibitor of AC, and one another, for example, dihydropyridine calcium channel blockers as combination. And we have the step 2, and so for us. And in the last step, where we have resistance, it's advised to refer our patient to the institution where this patient can be managed effectively by a specialized person. Well, this is the very important step after we have our patient in our system. We have this objective to achieve. The first one is the target. The target is to reduce blood pressure by at least 10 to 10, ideally less than 140-90 millimeter of mercury, and individualize it for elderly based on frailty. And continue monitor of BP control once achieved the target within 3 months, and paying attention for adverse effects, and to measure also and to be attentive for long-term adherence. And once again, referring people who, despite of observing all these measures, we have still difficult to control, to lower the level of blood pressure. Well, summarizing all things we've been talking about in this discussion, this diagram shows a comprehensive hypertension treatment protocol starting with an accurate pressure measurement and going through different steps until the follow-up. And for the time that we have, there is many things to talk about management, reminding that we are treating a person, we are treating a patient, even though we are focused on lowering the blood pressure. So we have reached the time and we have to press and to summarize as much as possible our discussion. So I give the word to Professor Matozo, and thank you.
For your presentation focusing on hypertension management according to current guidelines. You've given a panoramic consideration of the management approach. You have talked about the first step being making a diagnosis, measuring the blood pressure correctly. And you also mentioned the fact that there are guidelines to how to measure the blood pressure correctly. And, such guidelines are in the public domain. But by and large, in measuring the blood pressure correctly, we should note that the equipment must be right, the cuff must be right, the situation, the ambience or the milieu of the environment must be appropriate to get a correct blood pressure measured. We also mentioned the fact that the patient must also be in the right frame of mind while taking the blood pressure. You also mentioned treatment according to guidelines, ISH guideline, WHO guidelines, but we also need to emphasize the need for each country or the national societies, the Nigerian Hypertension Society, Ghana Hypertension Society or Cardiac Society, the Angolan Cardiac Society or Hypertension Society, all the various national bodies, that it is also expedient, it's good to also have national guidelines. Nigerian Hypertension Society has a current guideline in place. And in addition to that, we also have the treatment algorithm, which we should, for ease of understanding, particularly by healthcare practitioners, that they can quickly make reference to. There's a need to have all these guidelines, of course, situated within a global standard, the global standards of other global guidelines. Thank you very much for that. We also, in a nutshell, divided the management of hypertension into two: lifestyle modification and also pharmacotherapy or drug treatment. And under lifestyle modification, you talked about reducing alcohol intake, reducing salt intake, stopping cigarette smoking, regular exercise, and also being mindful. I'm going to use your word to reduce stress and also inculcate mindfulness. I think that's the way you put it. I think that's probably referring to internal management of stress. You also mentioned complementary, alternative, or traditional medicine. And this is a very, very important area that we need to say one or two more words. I'll ask you shortly, or maybe Dr. Doku as well, to say one or two things about this aspect of complementary, alternative, or traditional medicines, or even faith healing within the context of management of hypertension. How effective? How do you advise this to come to the fore? Do you advise that patients should engage in this? Some have recently talked about laser treatment, wristwatches, and all those things in the treatment of hypertension, Chinese tea, Korean tea, so many things in the market. I just want one of you later on to say one or two things on that. I think to kickstart, let's start with that. Let's start with correct measurement of the blood pressure. What do you mean by correct measurement? I've given the ingredients to that.
Hello, Prof. Okay.
Okay. I'll give the word, Doctor.
Okay.
Sorry, Doctor Sampes. Thank you for adding some aspect. Um, Actually, I had to press as much, to summarize as much as I can because I had only 10 to 15 minutes. And
I know. Yeah.
it's very easy to step off at this time. So I
Yeah.
had to compress as much and only focus on that general
Yeah.
aspect.
That's understood. That's understood. Yeah, the message to the audience is that we should go a step further and make sure that we know how to take the blood pressure correctly. I think that's a take home message to the audience that is mixed. Before you say somebody is, has established hypertension, you must know how to take the blood pressure correctly. You must know the stages that are involved. You don't take the blood pressure once and then you make that diagnosis in somebody whose blood pressure. We've seen a lot of cases. Somebody with a blood pressure of 145/90, and such people are started on medications. But the message to this audience is that it's stepwise, and there are steps in the algorithm, in the diagnosis, in measuring the blood pressure, and we should endeavor to find out about all these things. But remember, the equipment must be right, the environment must be suitable, the part of the equipment is the cuff, and so on and so forth. Okay. Dr. Doku was eager to say something about the faith healing.
Yeah, Prof, even before I mentioned that, the blood pressure, one of the things that are very helpful is when you're not sure, when you consistently have some moderate blood pressure level measurements in the hospital, it's always advisable to also look at what patient gets at home. Home blood pressure measurement by patient walking to the pharmacy or nearby clinic, because most of our hospitals are busy, the environment is very intimidating to the patient. So when you ask patients to monitor blood pressure at home and compare to what you get it gives you a fair idea what it is, rather than dwelling so much. But of course, if it's very severe or above 180, then you're very sure. But at times you're not sure because the environment, we cannot get it right. Patients come and wait for some 8 hours before they are seen. A noisy environment, most teaching hospitals across Africa. So let's also get this information from the patient where in the comfort of their home or in the comfort of the nearby clinic or pharmacy, they can also have their blood pressure checked. With the faith base and with all the things that are going on, I think the health professional, we need to confront this. We just, trying to condemn, the pastors, the jujumen. We are condemning the herbalists. But if I tell you the role they play in society and how they, ask our patients to stop taking the medication and then they come with all these complications, so it is always important that we engage these people, So for the Christians and the Muslims and then for the Jews and all the other people, I think we need to engage them that yes, God gave us this wisdom to discover these drugs, which have been discovered. Some of these drugs take about 20 years to discover and before they reach the market, And as Jesus came to this world, he had a lot of people who were sick. He couldn't heal all of them. So faith is important, but you need to take your medication and also pray to God. Yes, I mean, there's healing that can be healed as well. With the herbalists, yes, we also need to confront them scientifically because we need to have a national system to authenticate, these drugs, their side effects, their effectiveness. It's not right to just throw them away and say, look, these are not good. We have herbal, clinics, herbal centers across the country. We can bring them on board and try and bring science to their environment so that whatever they do, because most of these drugs had, herbal base in their development. So these herbalists, they control most of our patients. We can help them by bringing science to their laboratories to authenticate, to validate whatever they think works. Because some of them say one drug cures so many things. We need to sit down and engage them. What is the active ingredient? And then we can support them to develop one properly. Whether we like it or not, our patients will go to them. The professors, the doctors go to the herbalists. The PhD holder goes to the herbalist. Everybody goes to the herbalist in Africa. And so this is a time to engage them and see the best and the most scientific way to get them on board. Over to you, Prof.
Thank you very much for that. Let me just say one statement on what you said earlier on. The need to monitor the blood pressure at home vis-a-vis the hospital. And for the audience, what that brings up is the concept of white coat hypertension as well as masked hypertension. There have been studies and reports about these various types of hypertension, that the blood pressure may be persistently elevated in the hospital, but when the patient gets back home, it's normal, even without medications. Or vice versa, the patient measures it at home, and the home recording is slightly higher than the hospital recording. We're talking of these concepts of masked hypertension as well as white coat hypertension. And it's important that we should know about this. And the concept of measuring at home or monitoring the blood pressure will also bring in, because Dr. Gade said in some instances, primary care physicians should refer to the next level in certain situations. And we should please take note, we should take note of that, because it's not all cases that will be as straightforward. As such, a special center, ambulatory blood pressure monitoring can be done, which will record the blood pressure over a 24-hour period, which will also help in taking firm decision about diagnosis and also about the appropriate management to give such a patient. So thank you very much. But in the same vein, Dr. Gade says something, because let's say we've made the diagnosis. You have the patient in front of you. Dr. Doku mentioned the fact that Africa is a low resource country. Most people, the income is poor in most of our patients, and yet the patient is hypertensive and you have to treat. What do you advise in making treatment available to patients? What do you advise, either at individual level or government level, in making treatment available and affordable? What do you advise?
Well, I think that the governments have the main role. They play the main role to design policies of getting medicine for the designing program, effective program, and the policy to get medicine to treat patients. I think that the government have main role in this case. Individually, I think that we share the same reality here in Angola and the region. We have what we can call unbalanced reality. In one extreme, we have very poor people that can't afford one pill, and on the other hand, we have people that have some accepted condition that we have. They may be treated in the optimal setting, but generally speaking, I think that the government played the essential or the main role in establishing policy in the way to get medicine available to majority of patients who are known to have hypertension. And I think that many contribution may be done, but this is what I can present as opinion in this case.
Okay, thank you. You have mentioned the fact that government should play a role in making policies that will make medicines available and affordable. And such policies, I believe, should include, where it is not available, health insurance, mandatory for everybody, so that you don't have to pay out of pocket. And the health insurance would take care, and listing such NCDs, non-communicable diseases, on the insurance schemes, so that even the poorest of the poor can have, once it's on insurance, can have access to affordable medications. And Dr. Doku, what's your view about, in this same direction, what's your view about generics and branded products?
Hello, Prof. Thank you very much for such an important question. I think in Africa we can't run away from generic products, because the branded ones are way out of the pockets of most Africans. And second, most health insurance, especially the national health insurance in Africa, don't stock these drugs. So it's best. I mean, if you look at Europe, American, UK, and you look at Germany and several countries, yes, they've agreed with pharmaceutical companies, national, policymakers have agreed with pharmaceutical companies to produce generic products, that don't cost so much to the individual, to the insurance. So the same way in Africa, generics are very, very important, to bridge the gap that we have with access and affordability. So, but the best way to bridge that gap is to identify the right pharmaceutical companies that government can partner with to produce the generic in a safe environment, so that the efficacy and the efficiency and the safety of these drugs are not different from the branded ones. So for Prof, to reiterate, the generic ones are very important to save lives in Africa, because without them, most Africans cannot have their blood pressure controlled. Over.
Thank you very much. Before we move on to the questions from the audience, which we have harvested, let's say one or two more things about some strategic policies at community level, community program, in terms of to control blood pressure. For instance, at the community level, or generally, there should be a situation whereby all patients, let's say all adult patients that present in the hospital for whatever ailment, as a matter of policy, must have their blood pressure measured. Whether you are there for malaria or you are there for any other thing, there should be that policy that will incorporate blood pressure measurement into primary care. And this will put greater roles on the nurses, the community pharmacists, in terms of measuring the blood pressure at every contact with individuals. And such contacts will then encourage maybe referral to appropriate quarters, particularly for patients who have other cardiovascular risk factors that may be beyond that primary care level. So, one or two more words from Dr. Gadi about this strategic community approach in terms of the education or in terms of measuring the blood pressure or diagnosing the blood pressure. And then we'll wrap it up by reminding ourselves that part of lifestyle modification or part of prevention are the preventive strategies, from primordial strategies, that is primordial prevention, to primary prevention, to secondary prevention. We'll then wrap up this segment of the discussion. So, Dr. Gadi, one or two statements on that?
Well, as Professor Matosa mentioned, it's important to include in a primary at the primary level the blood pressure measurement. Saying that, Professor Matosa, I believe that he is talking about institutional measurements. Besides, we here in Angola, we've done some exercise extra institution. At the level of a society, we periodically go out in the street. We program some activity outside where we organize people. We use medical students, we use institutionals, and on a square, we set up a structure that everybody who pass can measure he can take his blood pressure. We do it once in 6 months each year. The last one was on April last month. And another strategy is going to the state or private companies, governmental private companies, and making a spontaneous measurement of blood pressure. We did it with the TV workers. It was last year, and we published this study. If I can remember, I'm going to present this study in Word at the World Federation in Brazil. Another activity we did concerning measurement of blood pressure to the companies. This activity we want that we keep it permanently, doing and spreading it through all workers. And this is the activity we are at the level of our society programming to do in the way to a primary prevention of hypertension.
Okay, thank you. Again, the message from that is that at every opportunity, we should endeavor, at every contact with patients, check the blood pressure as a practitioner. And you have also mentioned the concept of health outreaches to communities, churches, mosques, car parks, and so on and so forth, to educate, not only to measure blood pressure, but also to health educate people on how to prevent the various risk factors. Again, you've mentioned that the need for low salt. Government has a role to play in terms of making sure that all packaged foods have labels, and we know the limit of salt intake per day. So all those are will be on policy aspects. And just to remind us finally that the prevention aspect, you've talked about primordial prevention, making sure that low birth weight or good antenatal care to ensure that the incidence of low birth weight is reduced, knowing that such individuals later on in life, they develop high blood pressure. We'll also talk about primary prevention, all right? All those risk factors, you have mentioned them, or people who are predisposed, maybe an offspring of parents that are hypertensive, you need to start preventing, primarily, or people who already have it, secondary prevention, how to manage. And it's in that regards that this question goes quickly. It's from the audience. So one of the participants in the audience, that Dr. Gade or Dr. Doku, there's this problem of poor adherence or poor drug compliance in Africa. And he says, what are the causes and how can this be, how can we improve compliance to treatment?
Okay. All right. Thank you, Prof. I think compliance, adherence to medication is a major problem in Africa. It drives most of some of the complications that patients come with. But I think it's a multifactorial. Part of the problem comes from the health professionals. We don't have adequate interactions with our patients. One, telling them what the problem is, giving them an insight into what the problem is, that yes, hypertension, when you have it, is not because you've been bewitched or because you've done something wrong. We need to walk them through what the causes of hypertension are, the primary cause or the secondary causes of hypertension, and let them understand. We need to have that contact. Unfortunately, we spend less than 5 minutes with our patients. So they go, all we give them is prescriptions and then they leave. We don't have really material for them to go and read and follow up at home. So that information at the onset, at the time of diagnosis, is not there. The next level is access, and affordability. Affordability is key. Access, we're doing our best, but affordability is key. And so, yes, the person wants to do it, wants to take it, but cannot pay for it. Puts the prescription somewhere, because the primary focus at home is want to get food to eat, to pay school fees. Patients don't want to buy drugs for a disease they don't feel anything. They don't have any symptoms for. And so there are several chains of events. So a lot of it also depend on government and policy. A lot also depends on patient factors, poverty level, and then the practitioner or health system factors. So there are several factors that contribute to that. I think we all need to play our role. But for us as practitioners, as general practitioners, we need to try and explain things to our patient. Because some consultation, even before we tell the patient what the problem is, we've already written a prescription. We don't walk them through the medication, their side effects, what to expect, and especially for men, if we take medication that's not helping us perform at home, yes, we wouldn't want to take it, because for us the primary, aim is to have some form of enjoyment at home. So if this drug is going to create that problem, then we will not take. So these are things we need to walk the patient through, and if we're able to do that and try and solve the problem, access and affordability through national health insurance and policies and things, I think we'll be able to address the issue of compliance, and so that we can have blood pressure control.
Thank you. We must be
just adding to
Dr. Gade.
Okay, just adding to Dr. Doko. Another problem has to do with the adverse effect of medicine and the amount of pill that the patient have to take. And one of the strategies to solve this problem is to elaborate to elaborate strategy that one single pill must be several combinations. Just like in our meal here in Angola, right now we are using, for example, a combination of telmisartan with amlodipine, and it's very effective to lower. It's one pill that we are using to treat hypertension. I think that it's it's an association of one calcium blocker receptor and one diuretic. And just like Dr. Doku say about the cost, we're using sometimes a generic that it's costless. It's a one pill. It's costless and it's less. It has less adverse effect. I think that to solve this problem, we have to see in this aspect the amount of pill that the patient have to take and the less adverse effect of the treatment.
Thank you very much. You have emphasized the fact that part of the principle of pharmacotherapy is to use combination medications that act at different sites. And for the African, as much as possible, this will include a thiazide or thiazide-like diuretic. And by the time a patient is taking a thiazide or a diuretic and is taking maybe a calcium channel blocker that is to encourage vasodilatation, and at the same time you think for renal protection or cardiac protection, you want that patient to be on either ACE inhibitor or an ARB, it's already like 3 or 4 medications for somebody who is not too educated. And even for the educated ones, the convenience of taking so many pills at the same time or at different times of the day, different dosing regimens, that is what our panelists are saying, that it becomes easier if we have single pill combinations. You take a single pill that has these 3 different agents in one pill that a patient can take once, and it enhances compliance. That is what the message is, apart from us as practitioners being knowledgeable about these medications. And also, very quickly, is the fact that treatments must be individualized. Each patient has his own profile, the risk profile, and some other, considerations will make us individualize treatment. So that is also very important. And in that same regard, somebody has just asked the question from either of you, starting with Dr. Gadi. He says, which is more recommended considering efficacy? Is it ACE inhibitors or ARB, angiotensin receptor blockers? Which one is more recommended? That's a question coming from somebody in the audience.
Thank you, Professor. If you allow me, I'm going to take one of your words. Treatment is individualized. Every patient, considering its health situation. Overall, the advisable it's ACE by its advantages how can I say? It has many benefits in cardiovascular disease, not just in lowering blood pressure. It reduces mortality. There are several studies that prove that the using is protective for renal vascular disease in diabetics, and have many benefits in other problem that other than hypertension. But in some person, the ACE have many adverse effects, and in this kind of person, it's preferred using the ARBs in the place of ACE inhibitors.
Thank you very much. Dr. Doku, one more word on that.
Yes, so I think for head-to-head, most of them are the same, but I mean the key thing is to look at the individual and then the side effects of AC inhibitors, Some people cannot tolerate AC without cough or with angioedema, with all the other. And the RAS system, if you look at ARBs, they have more total RAS blockade compared to AC inhibitor. So putting all this together, I think that, ARBs have more, beneficial effects, looking at the side effects and all that profile compared to AC inhibitors. So yes, we need to individualize them, and temsirtan, as we mentioned, really has benefit beyond blood pressure control. We have the pleiotropic effects against the renal protection, against left ventricular hypertrophy, regression of left ventricular. So there's several benefits. So I would, given the chance, I would prefer an ARB like temsirtan, which can be combined with calcium channel blockers, which can be combined with another diuretic to have a more, all-rounded, approach to blood pressure control, and to have blood pressure that have benefit beyond blood pressure control. So that is what I would say. Yes. Thank you.
All right. I think I agree with that. ARBs and then ACE inhibitors, but then the key word, individualize the treatment, look at the side effect profile, and then choose appropriately. And once a patient, because there's somebody here that once the blood pressure is controlled, can the patient stop the medications? The answer is no. That once a person is diagnosed as having primary or essential hypertension, that person is on one form of treatment or the other for life. One form of treatment or the other, which may be lifestyle modification, which may be lifestyle modification plus medications. But that person is under monitoring and under one form of treatment or the other for life. It's different from treating malaria or one of these communicable diseases. You remove the cause and then the disease is cured. So I think that's a take-home message for the person who has that question. Dr. Doku, Dr. Gade, a question here is, what is the best drug to use for a patient with a blood pressure of 200 over 105 in the emergency room?
Okay, all right, Prof, thank you. So for this patient, we need to ascertain whether this person has hypertensive urgency or hypertensive emergency. So in emergency room, is this causing acute end organ damage, acute kidney injury, acute retinopathy, acute heart failure, acute myocardial infarction, acute hemorrhagic stroke, acute subarachnoid hemorrhage, or acute cerebral infarction, or encephalopathy, hypertensive encephalopathy, dissection, and things like that. So we need to ascertain that. So that the question did not, add that information. So in an emergency situation with acute end organ damage, hypertension emergency, I would recommend a parenteral antihypertensive medication, hydralazine, labetalol. You titrate to get the blood pressure down get about 25% of the mean blood pressure down within, an hour, so that acute end organ damage will come down. However, if this person comes to the casualty or the emergency room just because the blood pressure was found to be high, and so this is hypertensive urgency, because the blood pressure, the systolic is more than 100, more than 180. So this is somebody you need to find out why the blood pressure, is it a newly diagnosed hypertensive, or this person is a non-hypertensive who is not compliant on medication. You need to find the cause. If the problem is because the person is not compliant or the drugs are not effective, this is somebody you can start with a dual combination therapy, single pill combination therapy. You can start with temsirtan with hydrochlorothiazide or temsirtan with amlodipine, and then you can monitor the person in the hospital. If for one reason the person's blood pressure is still not controlled, you have the chance of giving amlodipine 10 milligram or going up, on the telmisartan, 40 to 80. So there's a possibility for that. But this, once the person came in an emergency, you need to monitor and make sure that you titrate to the person's blood pressure, and then before you can let the person go home and give a short-term duration for visit. If it's still not working, you can look at 3-in-1, single pill combination therapy, where you could have valsartan with amlodipine hydrocortisone. So these are options to improve compliance. So the answer is whether it's hypertension emergency or urgency, and then if it's an emergency, then parenteral medication are needed, and then when the person, then you change to oral medications with what I'm just mentioned. If it's just hypertension agency, then you confirm and then look at combination therapy to improve compliance. Thank you.
Thank you very much. Dr. Gade, do you have any statement on that?
Well, following Dr. Doku, I just started, we have to see the setting of the which setting we have this patient with this value. If we have, we are in the presence of target organ damage, or only high blood pressure by itself. But the rest, I think that if we are in presence of just a single elevation of blood pressure, I think that the measures are very well explained by Dr. Deco, and we have to, in the presence of target organ damage, we have to make a comprehensive assessment and to treat according to the situation in the emergency room. But that's it. I agree with the explanation of Dr. Duku.
Okay, thank you very much. Well, for the person who is concerned about involvement of other healthcare providers, particularly pharmacists, in community screening or education, I believe that most community screening by societies also involve other healthcare professionals, not just doctors. We have cardinal societies that also have affiliate members, that have associate members who are not necessarily doctors. And apart from that, when doing the MMM that we talked about, and you constitute a team at a particular center, such teams are heterogeneous. They are made up of doctors, nurses, pharmacists that also go together for community screening. But the observation is noted for areas where that is not operating. The message is that such teams, as much as possible, should be all inclusive. And I think that will address that concern. Well, so far, distinguished ladies and gentlemen, it's been quite enriching being part of this program. But before we draw the curtain, we need one or two more final statements from the panelists. If you have one, or if you want to say more, just say one or two things to you in 2 minutes. Dr. Gade, Dr. Doku.
Okay. Dr. Gade, please.
Dr. Gade.
Just thanking, tailoring the last words of Professor Mateo. If you, as you maybe noted, our society is not a society of cardiology. Our society is an Angolan society of cardiovascular disease and hypertension. And it involves not only a doctor, but as well as nurses, physiotherapists, nutritionists, and all people that are engaged in treatment of a person with cardiovascular disease. And in our activity of community measurement, community measurement tracking of hypertension and educating communities will involve all that profession. And it's very important. It's very much to involve more people than only the doctor. In mainly in the primary level of prevention of hypertension.
Thank you, Dr. Gade. It's been,
Hello, Prof.
yes, Dr. Doku.
Yes, so my recommendation or what I would say is this, that hypertension is killing us. We need to build capacity. We need to build this capacity in three fronts. One, build a health system capacity with national guidelines, national recommendations that can be used to train health professionals across the country to guide standardized way of managing patients. The second one is to take advantage, such as a name measurement month, to reach out to the community and organize community screening. That's the only way of picking people with hypertension and create opportunity for blood pressure to be measured as a policy at any point of care, as Prof mentioned, and also empower the lower level facilities, the CHIPS compound, the health centers, to go to the communities to measure blood pressure at home, and that can be linked to care. That is the only way we can detect those who are in the community with hypertension with another way. The third approach should be a population-based approach where we encourage people, to change their lifestyle. That is primordial prevention, increase exercise level, physical activity, and cutting down carbohydrate especially, which is the main poison now across Africa. That's the only way we can manage cardiovascular disease. Finally, I want to thank Charlene Healthcare for this great opportunity to commemorate May Measurement Month to bring attention to hypertension, which is killing us, and also thank Prof for your leadership and your chairmanship for this program. Thank you.
Thank you very much, Dr. Gade, Dr. Doku. You've been wonderful in your presentations, making things very lucid for everybody to understand. We appreciate your contribution. And you've literally summarized that one, hypertension is here to stay with us. However, we can do something to limit the disability that comes with hypertension by preventing at individual level, at community level, and also by appropriately treating individuals that have been diagnosed in terms of appropriate treatment by risk stratifying the patients, looking out for other risk factors and controlling or handling the risk factors. And when you have to treat, you have told us lifestyle modification, that can be done by everybody. What you take into your mouth has an impact on, on your health. Cut down on salt. If you can, stop alcohol. Don't smoke. Exercise. Reduce your weight. All these are very, eat vegetables and fruits. All these are helpful in controlling the blood pressure. And of course, when we have to use medications, we've been told that one, the prescription must be rational, must be backed by evidence. You have also said that it should be individualized. We should take care of this. We should educate the patient about the complications in order to improve compliance. And with all this total package, we expect that over the years or down the line, we will be able to reduce the burden of hypertension in people, particularly in sub-Saharan Africa without being selfish. Of course, globally, we should be able to, if we adopt all these approaches, we'll be able to reduce the burden of hypertension in our communities. Once again, I want to thank Shalina for asking us to take part in this discussion, and especially for asking me to anchor the program and coordinate. It's appreciated, and we hope you continue to render services to all of us. When I say all of us, I mean to the community in various forms. All right? And that is by way of contributing to humanity. And there's no reward that is greater than that, to make, to see that you're contributing to the well-being of humanity. Once again, I thank you very much, Dr. Rahul and your team. Dr. Gade from Angola, thank you very much. Dr. Doku from Ghana, and everybody listening from all over the world. So thank you for being part of this wonderful program. Thank you very much. Dr. Rahul, over to you.
Thank you so much, sir. Your words are well taken, and that is how we are doing such type of webinars. They are purely non-commercial, and this is 22nd webinar in this series. So other than webinar, we do conduct many physical educational programs at our learning center across sub-Saharan Africa. And regarding this particular webinar, thanks to the panel members, I mean, I have enjoyed it thoroughly being an audience. You have touched upon entire bandwidth of this particular problem, hypertension. Dr. Omotoso, thanks to you for wonderfully putting entire subject matter in small presentation. I know it is quite difficult, starting from the background of the problem to some boiling issues like the complications caused by the hypertension. Thanks to Dr. Doku for making very impactful, facts-driven presentation and bringing some eye-opening facts like less than 10% of hypertension patients are controlled. So it shows the compelling needs about starting from creating awareness to the control and management of this disease. And thanks to Dr. Gade for making very tailor-made management strategy for hypertension for our audience, starting from your recommendations coming from Pascal. I'm sure it is going to help our audience in the management of hypertension. Thank you so much once again to the panel members. And I would also like to pass on our sincere thanks to our audience who takes continuous interest in our programs. Thank you so much. And I would also like to convey our sincere thanks to professional bodies. They have been providing accreditation to our programs. Nigeria Medical Association, SOPPOG, and Medical and Dental Council of Ghana and PPB from Kenya. Thank you once again. And the last but the most important for audience, don't forget to take quiz so that you can download your certificate instantly. If you cannot immediately, then you will get an email on your register email ID to download the certificate. Thank you so much. Have a good day.